All right. Good morning, everyone. Welcome to TeleShadowing. We're live on YouTube. Please feel free to ask questions in the chat box as we go along, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Rafique. Dr. Rafique is the Specialist Registrar ST4 at Oxford University Hospital NHS Trust in the UK. She is also a member of the Royal College of Obstetricians and Gynecologists, having completed many degrees as a part of her career path. Now I'd like to request Dr. Rafique to begin today's session. Thank you.
Hi, good afternoon. Here is afternoon, so I will go by the time that we have here. So good afternoon to everyone. And the thing is that today we are going to discuss that how we are going to make the things feasible for someone to get a training job or at least working in UK. And the thing is that thereafter we will be discussing about gynae problem, that is endometriosis, in a short while. My apologies if my bleep rings because I'm on call today as well, but I have informed my workplace that I will be doing this teaching activity. So hopefully no one will be disturbing, but if it rings in between, so apologies. So first of all, if we talk about that how the things went, it's very easy to get training in Obs and Gynae in UK if you know that how you are going and what you are going to do. So it's basically depend upon your own mind map that which way you are going. Thing is that for me, if I start myself after completing the graduation in MRCOG, I just applied for the jobs through NHS portal to get any trust grade job, which was accepted after a very long time. It was not an easy go through to have this job. But what I will say that the first job is always a challenge, and thereafter the ways open for you once you start working over there in UK. So what I have done, I did my MRCOG and thereafter did the English exam and get the first NHS job. After doing the NHS job, I would suggest that when we are entering in NHS, we should keep our expectations very low because whatever level, whatever grade you are working, it's important that when you join, you start from a lower cadre. And it is very important for your own satisfaction as well as it is important for the safety of the patient and NHS itself as well, that you understand that how NHS works and how you are going to make your ways through this NHS system. Thereafter, I worked as SHO here and thereafter getting to the registrar post. And in the meantime, there were some announcement about ST3 entry, which is the middle grade entry into the training program. While I was doing this trust grade job, it was, it inspires me that how much they look after the trainee and how they have set objectives and how they are being guided. There are many things that are not done in our countries, in our training, that how we do, like managerial skills, being a leader, being a teacher as well. So these were the things that inspires me, that how their trainees are so much hardworking, not only clinically, but they are focusing on the other things as well, which are really important in this new era of medicine, because people don't take us as clinician only. They take us as managers as well, as leaders as well. So this is how the system was working, and therefore I said that okay, fine, whatever qualification I have, I would like to go through the training program, and this is how I applied and got selected for the training in Obs and Gynae. It was an ST3 training, so I completed 1 year and now ST4. And still a couple of years are left to go ahead to complete the training. But it is well said that once you start your journey, you will reach your goals. So
thank you, Dr. Rafique. And we just wanted to request you can also screen share your slides. I think that we are not able to see it right now.
Sorry?
I think that you're not screen sharing.
Okay. Is it now?
Yes, perfect.
Okay. And okay. So coming to that, why you have to choose Obs and Gynae? You should be aware that it is a challenging area. It is very much training to you in terms of working hours, in terms of work environment, in terms of affecting your family life as well. But equally, if we see that how I feel myself in this career, it is really something that I want to do because it is about women care that need a lot of empathy, really a communication skills that work very well, especially someone who is laboring, who is in so much agony, who is going through the cancer staging, who is going through menopause. So a lot of areas are there where you really feel that this is something that I can support. There are a lot of people around you. You can say that, okay, someone else can do, but why not to put our part in that area where we can see that, okay, I can communicate a bit better. I can be empathetic to someone. So this is something then it is for you. It has a fantastic scope in making a difference in people's life. And it is not that you are going to support women in pregnancy only. It is like all the area, not only medical education, as well as research, as well as going through the new innovative technology in Obs and Gynae. And this scope has been increased, especially when they have further subcategorized the things in terms of subspecialties. And it has made this a really interesting area to work on, especially someone who is really wanting to know that how we are going to work on IVF, how we are going to see the fetal anomalies, and how we are going to catch up with the genetic and elements. So these are the things that really enthusiast you that this OB/GYN is something that is for me. It has a very significant impact on people life, on your own life, supporting other people, supporting your hospital, family planning clinics. It's a frontline OB/GYN research work that is going on that need you young people to come in and bring us with new ideas and new work in research as well. So there are two ways. You can be obstetrician or you can be gynecologist. What the new concept is there, they think that we should have the skills of both of them, because with the new trend and with the work pressure on the consultant, the a person who is a mix of obstetrician as well as gynecologist is more, job opportunities as well as more acceptance in terms of getting a good place in anywhere in the NHS. However, you see that when we are working either in obstetrics or gynae, we work in a team, and this team include in obstetrics working with midwives. We also work with anesthesia all the time. However, when we speak about gynecology, keeping in that oncology, urogyne, and all this stuff, we all the time are in communication with radiologists, surgeons, as well as some other nurse specialists that are there to provide the high quality of care to all of these persons. It is when we see that how the OB/GYN training is there in UK, so it is run through specialty in UK. So the core and the specialty training modules are there. Total program, if you start from ST1, is 7 years long. And you have to do part 1 between ST2 to 3 and part 2 and 3 between ST5 to 6. And it is a mandatory thing to show your progression through all these years of your MRCOG, this UK training. So you have to obtain GMC registration before getting to the training program. And working in NHS in a non-training job, you can enter into the training either through foundation training or run through programs. So when we are talking about the foundation training, for a non-UK or European Union medical graduate, there if we need to obtain the foundation training either outside of the UK, and if we are doing, it should be equivalent to something that is accepted inside the UK. And the other thing is that if we do the foundation training by UK FPO, but I'm not much aware about what this is, but I heard that it is very difficult to get UK FPO, which is equivalent to house job or internship for a non-UK graduate to get into system for this. So how we are then going to do is that we need to provide them with our CREST forms. These CREST forms are the basic forms that start from very basic clinical skills, and it has to be signed off before we come and practically join NHS. These CREST forms or certificate of readiness to enter to the specialty training, it can be either from our own country consultants, we call them overseas consultant, or if we don't have them, we need to do observership or clinical attachment with someone in UK to get at least 3 months of observership, and then if they are happy and they sign us off for these CREST forms, this is then where we can apply further. In the run-through program, there are two ways to enter. Either you enter as ST1, which I would say that it is the best time if you are thinking that you are someone who fit the criteria for ST1, because I entered as ST3, but I have seen that there is a very clear difference between the way we talk or we take the things as compared to someone who has gone through ST1 and 2. And important thing is that you know your eligibility criteria, your CREST forms are ready. You have 24 months or less. If you have more than this experience, unfortunately, then it is not something that they will consider you as a person who fit into a training starting from ST1. And where and how these posts are being announced, these are usually announced on Oriel system, which is their system of getting all these training posts or advanced skills post, the specialty posts over there. So you then select your ST1 applications and apply through that. It is one of the very extensive and exhaustive list of things to do. But once you have done, it is done, and it is really very effective in terms of that you can put all your evidence, your CREST forms, your competencies signed off in the Oriel website, so that it will be saved for there onward whenever you apply or you reapply. These evidences will be there. However, there is certain expiry date of CREST forms as well. It is not on the top of my head, but I think if it is more than 6 months, we need to redo our CREST forms as well. And the other way is getting into ST3 training. It is, if we look at the numbers that are offered as at ST1 level and ST3 levels, we have seen that there is quite less number of ST3s that are being taken up as compared to ST1. So if you want to start from ST1, and this is really something that is very substantial, as well as there is a very good opportunity for you to get into it, because by the time we get to ST3, the number reduces, as well as with more and more induction that is going on for a couple of years, their need for ST3s may reduce in the coming years. That's why this is something that can be considered for someone who has more competencies as compared to ST1 ST1 and 2, and they think that they are someone who can compete and come into the ST3 training. However, it is not something that is not doable. If you know that what you are doing, what are your competencies that are required. The competencies do not include only the clinical skills, it include non-clinical skills as well if you are applying for ST3, in terms of doing some audits, some quality improvement projects, doing some teaching and education. So these are the things that they require for an ST3 to be able to do, regardless whether you are applying as a non-UK, as a IMG, or as an overseas candidate. but this is something is required. If we look at the statics, each year the number of the posts that are offered in Obs and Gynae are not very less. These are 227 posts that are offered, and these are the statics till 2019 that are available. However, the fill rate is also very significant. For example, the fill rate has been increased to about 90%. Therefore, if you want to make yourself look different to be taken up, this is something that you have to start work from today. And the last thing comes as subspecialty training. So someone who has done till ST5, 6, then they can opt for subspecialty training, which means that there are different area of subspecialization which are usually posted on BMJ. And in Obs and Gynae, it is Gynae Onco, Urogynae, reproductive medicine, maternal medicine, and fetal medicine. So these are the area where you can get subspecialty training after ST5. So for IMG to get OB/GYN training in UK, it's important that you have got your GMC, which you can do after doing either PLAB or MRCOG. Okay, and after getting that, apply yourself your CV to the NHS jobs, except any non-training or service job, whatever grade, whatever way it is. Do some work, understand NHS, and then start working on how you are going to get into the training by maintaining your portfolio, signing off your competencies, completing your exams. This is something that is very important to let yourself go through the flow of this water. So if someone has done MRCOG, they can either enter the system and then, for example, for me, I have done, but I still was inspired by the way the people are trained here. That's why I say, okay, fine, I will rejoin the training program, and I entered the training program. But if someone think that no, fine, I have done enough, no more trainings, so they can go through the Caesar pathway, which is just supporting the IMGs in NHS to apply to the consultant post. This is something that is done. However, it is very explicit as well. So there is a very long list of competencies that you have to do. If you know that what you are needed and you want to complete it and do it from your own countries, that's fine. And then apply to the GMC for a Caesar equivalence, that's fine. However, most of the people I have seen that they come here, complete these competencies within 2 years. That is the minimum time that they have to complete these competencies, and then apply for Caesar as a consultant post in NHS. Another way that has been introduced is through MTI program, and MTI training. It is also a training program for a couple of years, like 2 to 3 years program from different countries, and you will be granted a GMC registration. And then after doing your MTI, you can either go through your options of going back your home, or you can continue in UK. So this is how the things are happening. So this is a summary. So we can see that foundation training till FY1, 2 you completed, and then you start with the basic training, that is ST1 to training. Then you have to do your exam. After that, intermediate trainings will start, and this is 3-year training. It is also called as core training. So here is something that you need to complete your practical skills, and then comes the advanced training, which is like, for example, if you want to go to reproductive medicine ST6-7, you will say that, okay, I'm going to do my advanced training over there, either by choosing ATSM or doing subspecs, which is subspecialty training. So this is how the system works in Obs and Gynae in UK. So this is all about how the things are about OB/GYN training and jobs and opportunities in NHS and UK. Now we will just quickly go through one of the scenario that is very important. For me, my interest is in infertility. That's why we will talk a bit about endometriosis, because it is very closely related to infertile patients. So in this presentation, we will just, this is the content of the slides. We will just see that what exactly endometriosis is, what can be the reasons for this, what are the location and how they are going to impact on fertility or pain, different theories about the endometriosis, classification of endometriosis. Then we will go through that how we are going to diagnose and manage. I know that it will be a lot for you, but we will just make it simple, and I will skip the things that are really if you think that this is too much for you, we will skip those things. So what exactly the definition is? So if we see on this, the lining of the womb is made up of epithelium and stroma, which is confined to the cavity of the uterus. However, if we find this epithelium and stroma somewhere else, okay, like on the fallopian tube, on the ovaries, on the peritoneal wall, this is something called as endometriosis. But what if we find it in the myometrium? So if this epithelium and stroma is in the myometrium, we call it as adenomyosis. And if it is other than myometrium, any other place, it will be called as endometriosis. So this is how the definition of this endometriosis is there. However, we see that there are different ways of classifying it in terms of either it is superficial, and when we say superficial endometriosis, it means that it is just superficially located on the intrapelvic organs, and it is not more than 5 millimeter. However, if some endometriosis is more than 5 millimeter, this beyond the penetration, then we will say that this is something called as deep endometriosis. There is a third way that we describe endometriosis differently, is endometrioma, and it is usually a cyst that you form on the ovaries, and we call it as endometrioma. Why it is important to know about endometriosis? Because it has been becoming a global problem, especially when we see that how much of the women are getting affected. If we see globally, there is 176 million women are affected by endometriosis worldwide. And you know, if we count on numbers, 1 in 10 women is affected by endometriosis, and you know, most of them are in their reproductive age. And when they get affected in this age group, when they are most productive for the society, for their own homes, for their own careers, and they are stuck with endometriosis, it really reduces their own efficiency and effectivity in being a very healthy member of the community. So it is general, but we have seen that the patients who come to us with pelvic pain, about 12 to 32% of those may have endometriosis, but the incidence further increase if someone who come to us with infertility, and it increases to 21 to 48% for the patient who come for infertility, to find endometriosis as one of the reasons for that. That's why it got a global importance, and there are endometriosis days, there are endometriosis awareness weeks that are being celebrated everywhere, just to increase the awareness, just to increase the support of people who have endometriosis in the society, and let them know that what are the coping strategies in terms of dealing with endometriosis. When we talk about where we find, the most common area where we find endometriosis is ovary. And once we find it ovary, most likely we will find it as bilateral, means that both of the ovaries will be affected by endometriosis. And if we talk about percentage wise or frequency wise, majority of the time, like 60%, we find them in the female pelvic organs, like either on the tubes, or the uterosacral ligament, or in the pelvic lymph node area, or pelvic peritoneum over the uterus. So these are the most common areas. However, in 10 to 15% of the cases, it can be either on the bladder or sigmoid colon or GI tract, or in vagina we can find as endometrioma or endometrial cyst separately as well. Very rarely in like 5% of the cases, we find it in distant organs like lungs, kidney. It can come to the mucosal surfaces like nasal mucosa. However, it has also been seen in umbilicus and even in the episiotomy or surgical scars. If we talk about what is the exact reason to find endometriosis, why some of the women get endometriosis, so most of the time we don't know, but we find that it is very closely related to the hormone changes. Therefore, we find that age might be one of the determining factor to find endometriosis. And average age, it can be from the menarche to menopause. Any woman can present with endometriosis, but most common is between 30 to 40 that we find that the woman can present. And the other thing is that pregnancy is a shield in terms of protecting for endometriosis, but has never been recommended that someone should get pregnant to get rid of endometriosis. But we have seen that about 50 to 70 of the patients who get endometriosis are usually nulliparous. There is a very close relationship of endometriosis with genetic factor, and why we find that is that if someone has a very close sibling or mother or sister being affected by endometriosis, the chances of that patient having endometriosis is 10 times as compared to someone who don't have any first degree relative affected by endometriosis. So this is why we think that there might be some element of genetics in acquiring endometriosis. When looking at social and economical factor, we find that it is more common in highly civilized communities. How this endometriosis has been generated, what are the theories behind endometriosis? So there are three theories. Sampson, Meyer, and Helben has proposed different theories. So we will go quickly one by one through them. So Sampson said that there is retrograde menstruation, means that whenever we have periods, the lining of the womb is going to shed off, and instead of coming down through the vagina outside, it just flow backwards through the fallopian tube and spill into the peritoneal cavity. This is how it is going to lead to endometriosis. Another theory by Mayer and Ionov is celomic metaplasia. So what they said that if someone has repeated infection or there is any hormonal impact that is going to cause a chronic irritation in the peritoneal wall, it leads to the celomic metaplasia, which is change of multipotent cells from one type to another type, and this lead to change and endometriosis formation to the pelvic cavity. But Halpin found, once we find that endometriosis is not limited to the pelvic area, it can be found distantly, then the theory of Halpin came into place, and it suggests that this endometrial tissue or stroma, it is taken up by the blood vessels, especially lymphatics, from the uterine area, and it is then transported to different distant organ where it leads to deposits, and then every month it responds to the hormonal changes. This can be either the surgically entered uterine cavity in cases of cesarean section that we very commonly do. So this is about etiology and what are the possible theories of having endometriosis. When we talk about how the woman is going to present to us, that click in our mind that okay, this is endometriosis, this is endometriosis. So we can't say anything because there is no correlation, especially in terms of nature and severity of the symptoms. They never correlate with how extensive the disease that we may find once we're really going to explore endometriosis. Some of the women, they do really present with nothing. They just come to us going through a surgery for something else, and we find, oh my God, there is extensive endometriosis. But some of the women that come to us, especially with pain, infertility, these are the two things that rings bell in mind that okay, yeah, this can be endometriosis. But the pain can be different way. So it is not only dysmenorrhea, that is the pain associated with the periods. It can be deep dyspareunia, means pain while having sex. It can be ovulatory pain, and many of the women with chronic pelvic pain, they are someone who have endometriosis as well. Infertility is the second most common presentation of the patients with endometriosis. And we have seen that there is cyclical changes in the bowel and the bladder that are associated with or without abnormal bleeding that also give us a clinical feature of having endometriosis. However, strangely but interestingly, we find that most of the patients who have endometriosis, they usually present with chronic fatigue as well. So this is just a repetition of this, but being used, thinking about those symptoms that are very common in gynae to make sure that whether it is really fixing in endometriosis or not. So if we talk about pain, it can be adenomyosis, it can be like without any reason the patient may having dysmenorrhea. So how you think that this dysmenorrhea is related to endometriosis is that the pain starts prior to menstruation and get worsened during the menstruation. And we see that this dysmenorrhea is due to release of prostaglandins from the endometriotic tissue at the time of menstruation. When we talk about dyspareunia, it's very important that what type of dyspareunia it is. It is whether it is superficial or deep. So if we look at the pathophysiology of endometriosis, we see that it leads to scarring or adhesion formation in the pouch of Douglas, making uterus a bit fixed. So this is something when a patient will say that she has deep dyspareunia rather than superficial dyspareunia. More frequently, the patient, about 30 to 50%, will present with infertility, and that also because of the scarring and the adhesion formation, and especially if the tubes get distorted at that time of scarring, it leads to infertility. Some of the women, especially someone who has associated adenomyosis, they can present with menorrhagia as well. But if someone has deposits of these endometriosis on the sigmoid colon or GI tract, they may present either with constipation or diarrhea and sometimes even dyschezia. If the deposits are on the bladder, they lead to flank pain, abdominal pain, hematuria, increased frequency and urgency that really mix up with either UTI or having other urogyne problems. That's why we need to be very vigilant in seeing that what is the correlation of these pain symptoms with the periods. Someone who have distant endometriosis that is implanted in the lungs, they may present with pneumothorax or hemoptysis. So how, when we are in the clinic, what we are thinking when someone come to us? So I talk about in my clinical suspicion is that, okay, yeah, this patient is endometriosis. So at that time, my mind starts saying to my finger that what I'm going to palpate. Okay, so when we are going to palpate for a patient of endometriosis, it's very important that doing vaginal examination is important in terms of looking for any induration in the rectovaginal septum, looking for so this is in the center, then you go to the side walls and you see that whether there is any nodularity, which is a very classical sign of endometriosis. This nodularity in cul-de-sac, a fixed retroverted uterus, and then you put your second hand on the tummy to see that whether there is any localized adnexal mass or pelvic tenderness that is present over there or not. So this is how you will be thinking when you are going to examine a patient of endometriosis. So what other differentials can come into your mind when you are looking after a patient of endometriosis? So if someone is coming to me with sudden abdominal pain, I will say, okay, it is ectopic. It is ectopic. First of all, reproductive age, abdominal pain, acute pain, ectopic. Okay, pregnancy test negative, fine. It can be acute PID or torsion or a ruptured endometrioma. So these are something in case of sudden acute abdominal pain. But if it is a chronic pain, then obviously then you have to see that, okay, it can be endometriosis, but what it cannot be, how I have to exclude, what I have to exclude. So chronic PID, pelvic adhesions, ovarian neoplasm, IBS, and other reasons of chronic pelvic pain you have to exclude before you say that, okay, it is something that is pain associated with endometriosis. So then comes that how you are going to make sure that really you are dealing with endometriosis. So transvaginal scans are done, and they usually have very good place in diagnosing endometriomas. However, how they are going to look for adhesions, how they are going to look for involvement of bladder or rectum, it's not very supported by evidence that whether doing only transvaginal scan is going to give us a full picture of endometriosis or not. That's why we then suggest MRI, which is equivocal to ultrasound, but it is something that is not available at every workplace. And when we compare ultrasound and MRI to laparoscopy, we find insufficient evidence to quantify all of three modalities to diagnose, because what we find is that the gold standard to diagnose endometriosis is doing laparoscopy. So this is the definitive diagnosis is made by that, unless disease is really visible on vagina or somewhere like obvious on the body parts. It's important that when we are doing laparoscopy, we take histology and it confirms the diagnosis of endometriosis as well. But you know what happens? There is a delay of at least 7 years for a patient to get a definitive diagnosis of endometriosis from the first presentation of pain or infertility, if they are not going to expedite or they are not going to go through the investigation or diagnostic pathways. So this long period of having delay of 7 years, it really affects healthcare settings. Looking at the CA125 levels, we know that it is one of the glycoprotein we do to see that whether there is any association of this in endometriosis or not. And extensive work up has been done, and we could not find that it is really a reliable screening test to diagnose endometriosis. Because it is very non-specific, and we have seen that it can be raised in other conditions such as PID, adenomyosis, even neomyomas. Even someone who is pregnant or even menstruating, CA125 level can rise during that as well. Not only the gynecological condition, we find that CA125 level can be raised in any GI problems or any liver problems or pancreatic problems as well. Therefore, CA125 level are not commonly used as a screening test for diagnosing endometriosis. So then we come that how we are going to classify endometriosis. So when we are talking about classification, they have staged it into 4 stages: minimal, mild, moderate, and severe. So if it is only superficial implants, they call it as stage 1 or minimal disease. When more implants and a bit deeper involvement, they say mild. When there are more implants and ovaries start getting affected with some adhesions as well, they say it's moderate. And when multiple implants that are deeper involving the ovaries, involving the adhesions as well, they call it as a severe endometriosis. So far, accepted classification of endometriosis is from the American Society of Reproductive Medicine. However, it is really very, very extensive in terms of realizing that, okay, how we are going to remember this. So first of all, stages are the same, but just a couple of things that to understand. So they are looking for endometriosis either in the ovaries or the peritoneum. They are looking for the cul-de-sac, and they are looking for adhesions. The adhesions can be on the tubes or can be in the ovaries. Okay. Thereafter, this look for the size of these endometrioma. Thereafter look for the adhesions, that how much enclosure they are going to cause. But the maximum number they give to the posterior cul-de-sac obturation, and the number they have given to 40. However, this number varies. Superficial endometriosis get 20. Deep endometriosis get 20. Thereafter, if there is dense adherence, it gets 16. So this is how they score this, and they put it on a photographic way as well, just to let everyone know that how they have classified it. So this is how they are going to classify endometriosis. So what is important in terms of diagnosis, that you know the symptoms, you exclude other causes of having pelvic pain. It is always good practice to ask the patient to make a diary of these symptoms, because it will help not only for you to understand the pattern, but also the correlation of these symptoms with either bowel problem or the urinary problem, or either with the periods. So this is very important. That's why we expect and we suggest most of the patients that are coming to clinic to have pain diary, to help us as well as to have a better understanding of their pain as well. Thereafter, you did the examination. There are no biomarkers that we are using as screening for endometriosis, and negative imaging like scanning or the MRI does not extensively give us a result that, okay, this patient is not going to have endometriosis. Thereafter, we start that whether there are any signs of endometriosis. If there are signs, we are going directly to the endometriosis treatment. However, if there are no signs, then we empirically start them on treatment, which we will be discussing that what treatment options we have. So we empirically start on the treatment and see whether it is successful or not. If it is successful, fine. But if not, then we offer them diagnostic laparoscopy and combined with surgical treatment as well, and confirming the diagnosis with histology as well. So this is the H3 recommendation for the diagnosis of endometriosis. When it comes to treatment, it's very important. It's not our body, it's not our decision that what treatment that we are going to give, because it is patient, what type of treatment the patient need, to what extent he want her symptoms to be resolved, what are the main concern, whether it is the pain that she want to get rid of, or she is really desperate to get pregnant, or it is really something pelvic pain that is affecting her quality of life and she just want to be pain free. That's why she's with us. So this is how our treatment options will depend on patient decision, our decision, as well as what we exactly have in terms of diagnosis of endometriosis and stage of endometriosis. However, generally we have expectant, medical, surgical, and combination of treatments. But it is important that we as clinician or gynecologists know that it is not that endometriosis we are going to treat. It is a patient that we are going to treat. So we need to have a comprehensive, holistic approach to the patient. It is not just writing hormones to the patient and saying that, okay, it will work out. Just let them speak out, understand them, give them some general advices, because these are something that really affect in terms of improved counseling of the patient and help them to understand that what coping strategies or what other ways of coping up with the pain they can adopt in their life. That's why we suggest pain relief medicine, simple pain relief, NSAIDs, analgesics, lifestyle modification, referral to the pain clinic. Anxiety and depression is very common because someone going through pain for 7 years, it's very, very optimistic for them to have anxiety or depression going through all these years. For us, it's important that we have very empathetic approach to them, and we do suggest expectant management only for the patients who have very limited disease or who have minimal symptoms. For example, I did a laparoscopy for a patient and I see, oh, there is endometriosis, but the patient don't have any pain. There is no fertility concern. So there is no need to treat that patient until or unless she say that, yes, I'm suffering with this pain. or I really need to have children and I want to go ahead, and then we will explore that what options we have. When we are going to talk about the medical treatment, just from the very start of the talk, what endometriosis is. It is hormone-dependent epithelium and stroma. So what if we shut down these hormones, or at least suppress them? So if we will suppress them, this epithelium and the stroma will automatically sleep, and then the symptoms will resolve. So this is the theory behind starting medical management for endometriosis. So what we give are exogenous hormones to create a pseudo-pregnancy state or a pseudomenopausal state, either by selecting contraceptive pills or danazol or GnRH analogs to let them free of their symptoms. And we usually start this treatment for someone who is beyond minimal disease and someone who desire pregnancy in future as well. But it's very important then when we are talking about medical options to let them know that the symptoms can recur once we stop the treatment. In terms of combined contraceptive pills, we give them as continuous therapy without 7-day break. But it's important that it is very, very easy to administer, it's low side effects, and we choose contraceptive pills as first line along with NSAIDs to treat endometriosis. However, women should be aware of the possible side effect in terms of weight gain, breakthrough bleeding, some breast tenderness, and bloating as well. The other option are the progestogens. So progestogens are for someone who don't want to have contraception. For example, a patient come and she said to you that, okay, I want to get pregnant, and you suggest, okay, hormones I can give. We can't give them oral contraceptives. So progestins come at that point to help you out. So we have DMPA and implants that cause the atrophy of the endometrial tissue. However, it's important that women do understand the possible side effect of weight gain, fluid retention, some depression element, and bone demineralization if we choose them as a long-term therapy. Danazol, it is not a very favorite drug because of the hypoestrogenic and androgenic side effects. However, what it do is that it suppresses the mid-cycle FSH and LH, and then the ovaries are not going to produce estrogen. However, because it reduces libido and it causes deepening of the voice, the query that is reversible or not reversible, with very strong association of oily acne, oily skin and acne, most of the women do not opt for that. This is GNR and GNRH analogs that are quite famous and not only used as treatment, but also to quantify some of the surgical options for many of the patients that are going through the gynae as well. So what GNRH analog are going to do that they downregulate the pituitary GNRH receptors, and it creates a state of pseudomenopause, or we call it as medical oophorectomy. However, when we say that it is a pseudomenopause, it means that it is going to generate some menopausal symptom among the women like hot flashes, vaginal dryness, insomnia. Libido is not much affected as compared to danazol, but it do affect with GnRH analogs as well. Some patients complain of fatigue as well. And the important thing is that we need to, if we are going to use GnRH analog more than 6 months, it should be like with add-back therapy to prevent any bone loss or hypoestrogenic side effects. So if a patient is coming only for pain, you go through your differentials. You have 3 options: pain relief, you have hormonal options, and we have surgical options. First, what we will do, we discuss all the side effect, whether this patient really fit into the treatment criteria or not, and then ask the patient to make a choice, her preference, and thereafter we go. It is not necessarily that we start with one we usually start with a combination of NSAID and hormonal treatment and at least 3 months and see that whether it is effective or not. If not, the patient can switch to another treatment. For example, combined pills and progestogens are first line. However, GnRH are second line. So if a patient say that, okay, the first line does not suit to me, then we can offer second line before we offer them surgical options. So this is how the flow of pain management goes with the patient of endometriosis. However, if someone come to us with fertility problem, so there has been really extensive work has been done in terms of going through the randomized controlled trials, doing some systematic reviews that what is exactly in terms of improving the fertility of the patient. So doing ovarian suppression as adjuvant to surgery, it shows no benefits in terms of fertility outcomes. However, it do increase the cost of fertility treatment as well as delay the pregnancy. Therefore, ovulation suppression is not something that is advised as adjuvant to do surgery in terms of improving the fertility outcome of patient who is having endometriosis. If a patient is going for IUI, should we give them GnRH analogs? It is also not recommended yet that we should give them, because most of the women who go through IUI are usually mild or minimal disease, and they have a very good potential to get pregnant with simple IUI. Someone who has minimal or mild endometriosis, there is insufficient data to recommend that laparoscopic surgeries should be done before ovulation stimulation or IUI. However, someone who has moderate and severe endometriosis, they really fill the criteria to have a surgery in terms of adhesiolysis or cystectomies or any other invasive procedures in terms of making them to a potential fertility treatment so that it improves the outcome in terms of getting a successful pregnancy when we are going to offer them any fertility options. So this is how the treatment for the infertility goes. So hormonal treatment is not something that we offer for a patient who come for fertility problem. We offer them either medically assisted reproduction or we offer them surgery. There is another grading area which we call as endometriosis fertility index, which is used to see that whether this patient is going to have a spontaneous pregnancy or she is something who may be helped out by assisted reproduction. However, it is very extensive and it is something that is the talk of subspec that I have not gone through yet. So this is about endometriosis. If we find endometrioma, which is like a cyst-like structure on the ovaries, what we need to do? So if a patient is infertile and she came to us with ovarian endometrioma, so we should excise that endometrioma. So the incision and coagulation of endometrioma is not something that is going to increase the pregnancy potential of that woman. So it's very important that we need to take out all the endometrioma out of its capsule when a patient with infertility and ovarian endometrioma is with us. However, when we are taking out these endometriomas, we might take some of the normal ovarian tissue as well. So it's important that we talk to the patient that there might be a risk of reduced ovarian function after surgery and possible loss of the ovary if it's very difficult to take out endometrioma. And whether we are going to proceed ahead with surgeries who already have a previous ovarian surgery. For example, a patient come to you 5 years ago and has had already excision of endometrioma from the right ovary, and she comes to you with another endometrioma on the left side. So you should, it's really a MDT approach rather than an individual decision to go ahead with the treatment of endometriosis. In terms of that, obviously, if you are going to deal with the contralateral ovary with the same risk of a reduction in the ovarian function with surgery, then it should be a team involvement rather than individual decision. So in terms of surgery, what we have, we do have removal of the endometrioma, which can be considered if we take out all the endometrioma as a definitive surgery. But in endometriosis, we usually have very widespread lesions, so it is not possible to do a very definitive surgery. There is always a risk that something will be left or something will reform after the surgery as well. So this is something that is not possible in case of endometriosis. We do suggest some conservative surgery in means of freeing some adhesions that not only relieve the pain but improve the sexual function as well as fertility outcome in terms of patient with endometriosis. And it is usually indicated for women who want fertility and someone who has failed symptom control by medical management. When we do laparoscopy, endometriosis is seen in two ways. Either it will be like black lesion on the pelvic wall. This can be small nodules or small cyst, and it suggests that it is something like old hemorrhage that is surrounded by a variable degree of fibrosis. And the term we use is Potter burn or gunshot lesions for them. But if there is scarring and formation of some scar tissue around this area of glandular and stromal element, they can be brownish or whitish in appearance, and we call them as white lesions. They are mainly composed of fibromuscular element, and they cause peritoneal defects, sub-ovarian adhesions, and it is very common to contain endometriosis in 40 to 70% of the cases in which there are subovarian adhesions to find out these white lesions or fibromuscular lesions. So this is something that we did the laparoscopy and find that how this endometriosis look like. It is like a more closer view of the pouch of Douglas showing that how endometriosis look like on laparoscopy. This is something endometrioma that is very confined to one of the ovaries, and it is another very well confined cyst that we find, which later on dissection comes to be a chocolate cyst or endometrioma. And when we are doing laparoscopy, in our mind we are running three things. It's implant excision that we have to do. If not, then we have to burn them away, or if we can remove them or not. There are different lasers that has been introduced, but so far I am not aware that whether these are being used in UK or not. So this is one of the endometrial cysts that has been dissected, and when we have a cross section of this cyst, this is how it looked like, and that's why it is called as chocolate cyst. This is how laparoscopy works, but are we really doing laparotomies? It is not something that we usually do until or unless that a patient cannot go ahead for the laparoscopic procedure because of some underlying medical condition or someone with advanced stages of endometriosis in which laparoscopic excision is not possible. And what we usually do is THBSO, means removing the tubes, ovaries, as well as the uterus. If there are superficial peritoneal surface implants, we are usually excising them. Endometrioma, we are excising them, and adhesiolysis is something that we usually do. So I'm not going to go in detail of that because it will be too much in terms of endometriosis. But NICE guidelines are something that are very important, and if you are going to work in UK, this should be at your fingertips. We do go back to NICE, not only for patient counseling, for our knowledge, as well as in terms of if there is any medical legal case. If we have done something according to the NICE guidelines, it is going to protect you as well. However, each hospital, each trust has their own guidelines as well. So NICE guideline has very extensive, like full detail of endometriosis and how we are going to treat it, what we are going to do. But there are flowcharts that are very easy to remember. And the good thing is that they are classified according to the number of visits that woman is going to present. And what different from other guidelines like ASHRI they have done is that they have touched on the psychological aspect of the woman going through the pain and infertility as well. So when a patient first come to us, just going through the symptomatology, addressing the patient need as well as supporting her, and then discussing about the pain diary, offering the examination. Thereafter, initial management is to go ahead with the short trial of 3 months for a combination of pain relief and hormone preparation. However, NICE guidelines say that if someone is not going to be affected and she is coming to us only solely because of the pain, we can refer them for neuropathic pain management or with some neuromodulators as well. So if the fertility is priority, then there is a separate flow chart for that. However, when a patient comes with pain and it is not being managed by empirical treatment, what is important that we do a proper referral, and this referral should be to the gynae services. If the patient age is like in this area that we need to refer to the pediatric or adolescent gynae, we need to do that as well. And there are every area we have endometriosis services specialists that are available to look more closer at how the pain is going to happen or what in terms of fertility options that we can have, not only that long-term follow-up and support of the patients of endometriosis. This is something that these endometriosis services and endometriosis specialists are going to look after. So then this is something that if a woman have priority as fertility is the main concern of that woman to come to your clinic, then we offer excision and ablation plus minus adhesiolysis to that woman. And we usually do not offer hormonal treatment to those women who want to get pregnant. If fertility is not currently a priority, then we can consider excision rather than ablation for the treatment of endometriomas. And for those in which fertility is not a priority, we can offer them GnRH before offering them surgery. So BMJ, which is one of another very commonly referred educational website, and similar to NICE, then when we are going to base our knowledge and we are talking to the patient, it has produced this one-page visual summary of how we are going to treat endometriosis, which is again something that we already have gone through. The only thing is that they say that we need to individualize our approach to the endometriosis patient, and our support to them should also be individualized, that what they exactly want from us. And early referral has been recommended by them as well. I know it's a lot that I'm saying, but it's about to finish. What about pregnancy? Because as I told you that you're not, you can be what you want to be, but you need to see that what is heart favorite at the moment. So a combination of gynae and obstetrics is more favorite as compared to a single specialist. So we need to see that if someone comes to us and she either want to get pregnant or she is already pregnant, what will happen if she has endometriosis? So pregnancy itself have variable effect on endometriosis. Okay, and as I told you that we should not ask a woman that you get pregnant and your endometriosis will be resolved just as a treatment for endometriosis, because it is not a confirmed that pregnancy is really going to improve the symptoms, okay, or reduce the disease progression. So it's very variable effect. And how endometriosis is going to affect the pregnancy is that it increases the chances of early pregnancy loss, and obviously because of adhesion scarring, it causes increased chances of having ectopic pregnancy as well. However, they say that other obstetrical complications are also increased in someone who get pregnant with endometriosis, but it is not an indication for additional antenatal monitoring or additional scanning or additional um, uh, any further need of increasing the visits of that woman to the antenatal clinic if she get pregnant with endometriosis. So these are some of the references that I have quoted for this presentation. So this is something that we, it's very difficult to realize that if we can't see, it does not mean that it does not exist, and it really fixed to the someone who is suffering from endometriosis for a very long time. So it's if we in our mind know that something can get really hurt by endometriosis, and if they are saying that they are in pain and they are in pain for a very long time, we should consider them and we should take it very empathetically that how we are going to offer them the options of treatment. Any questions?
Hello, Dr. Rafique. My name is Hamza. I'll be doing the Q&A session. I'm in a joint BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine. So to start off the Q&A, the first question I have is, has COVID impacted maternal care since more complications can go uncaught because of women trying to avoid the doctor's office?
Can you repeat, Hamza, your question? The connection was just lost.
Right. How has COVID impacted maternal care since more complications can go uncaught because of women's trying to avoid the doctor's office?
So COVID itself do not increase the chances of having endometriosis. However, what COVID has done that we globally went through delay in gynae referrals, gynae surgical list has been reduced. So what happened that the woman who was having endometriosis, their referral get delayed, their operations get delayed because of COVID, and it obviously increases the time for them to get pregnant as well. Because of this, some of the patients who was for fertility treatment, they divert to private services as well. So this is how COVID has impacted in terms of patients of endometriosis. But whether it is one of the reason to step up someone endometriosis from a minimal to moderate, this has not been evidenced yet.
Thank you very much for the answer. The next question we have is, what is the importance of regular menstrual cycles in women? Would an irregular cycle indicate reduced fertility?
So regular cycle do means, and it is one of the very diagnostic of ovulation every month. So it do suggest to us that yes, this patient is menstruating or ovulating every month if she's having a regular periods. Irregular periods or anovulatory periods, these do worry us in terms of either what's going on, why she's not menstruating, because the uterus is made in such a way that it is get prepared every month for a menstrual cycle, because every month the ovaries are supposed to produce the ovum. And what can be the reason? So anovulatory cycles are either can be hormonal reasons or exogenous medicines. So it's important that we rule out that what exactly is the cause. Some of the time it can be due to polycystic ovaries, some other androgen secreting tumor as well. So these are something that can cause, but this is not limited to that. It is even nutritional deficiency is going to cause the anovulatory cycles. Stress is going to cause, excessive exercise is going to cause periods problems. So this is something is very delicate area, but anovulatory cycles do mean that we should get investigations early rather than late, or find out if there is any general factors that are going to cause anovulatory cycles, to address them. I would suggest that someone who has anovulation, no periods or abnormal periods, they still, for example, we give Mirena coil to some of the patients. However, they do recognize that they are ovulating. They find their body that they are still ovulating. So putting Mirena coil does not mean that the ovum is not being released from the ovary. So they do recognize there are different way of finding out that whether your body, like body temperature rise, mood changes, these are all other ways of recognizing self and finding out that other than menstrual cycle, there are ways to find out ovulation or not.
Thank you very much for that answer. The next question we have is, what is the cause of polycystic ovarian syndrome, and how do you treat your patients effectively by PCOS if it affects fertility?
So it is polycystic ovarian syndrome, is it right?
Yes. Yes.
So it is outside of the talk of endometriosis, which we focus on today. However, polycystic ovarian syndrome, it is again androgenic problem, means endocrine problem. And what is going to happen that it is a symptom complex with combination of biochemical and scan pictures. So we do have Amsterdam criteria to classify any woman who have polycystic ovaries or not. So what we exactly classify is that patients who have acne, hair growth, and menstrual problem as well. And then we have a biochemical picture that shows that yes, there are extra androgens activity. In addition to that, we need to find out that there is no other hormonal problem. For example, thyroids are functioning normal, there is no testosterone secreting tumors, there is no adrenal problems. So once we exclude all these causes and we are sure that this is the hormonal picture with abnormal FSH, LH level, androgen fertility index is this much, and then we say that, okay, the third criteria is to do a scan. And when we do scan, we say that there is a polycystic appearance of the ovaries, which means that at least more than 12 follicles in both ovaries, we can see that that was a previous criteria. Now they have started focusing on the ovarian volume as well. So these three combination of the things, that is clinical picture, biochemical picture, and the scan picture, are used to diagnose a patient of polycystic ovaries. And it is a huge talk. If you are interested, I can make another lecture and it will be a full session on that.
All right. Thank you very much for that answer as well. One more question I have is, what are the most challenging aspects of working in OBGYN?
What is the most?
What are the most challenging aspects of working in OBGYN?
Oh, yeah. It is a very good question. Thing is that it's very, for example, you join Obs and Gynae because it is very energetic, a combination of medicine, surgery, everything you find here, oncology and innovative technology, urology, everything is here. But keeping in the long on calls, working in unsocial hours, it do affect you in terms of your spirit to go ahead with the specialty. Sometime we find that the candidates or the trainees, they get burnout because of this. But this is something I find in UK. There is professional well-being and support services that are available in each trust, and you can't believe that they are so open to accept these negative feeling of being burned out, feeling a bullying, and feeling that there is unhealthy environment, like environment of senior and junior, and talking to each other in not a very professional way or not in an empathic way. So it is very well supported, especially in terms of Obs and Gynae in UK. So these, and the other thing is like that I would say that is the work-life balance. How you are going to have the impact of having OB-GYN and then maintaining your family life as well. But I did not have it before, but here, for example, in UK, I am less than full term, means that I have many days off to spend with my children. And when I am on duty, my children know that mom is not there, but mom have 3-4 days at home. So they have in UK, Obs and Gynae, they have made it very compatible for the human needs, for the challenges, as well as possible negative impact of this specialty. And there is a lot of support in terms of understanding yourself, going through the stressful situation, and mindfulness training as well. So these are the side effects of this, Obs and Gynae, as well as that what you have in terms of dealing with these challenges. So these challenges are there, but these challenges are not something that are not treatable, or you don't have support for that. For me, I think in UK we do have support for managing these challenges in Obs and Gynae.
Thank you very much, Dr. Rafique. That's all the questions we have for today.
Thank you. So nice of you.
Thank you very much, Dr. Rafique. We really appreciate you taking the time to answer all of our questions and taking the time out of your day to mentor us. I'd love everyone to please give a warm thank you to Dr. Rafique in the chat box for this incredibly informative session. Thank you.
Thank you, everyone.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live, and you'll need a 70% or higher to pass and receive certification. And the link to the quiz is being sent in the chat right now. And for our next session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, April 16th at 10 a.m. Eastern Standard Time with our physician mentoring us in ophthalmology. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.
Thank you. Thank you, everyone.